Okay, well, it gives me great pleasure to open our next session on achieving VTE exemplar status, where I welcomed Christine Welburn. Christine is a thromboprophylaxis clinical nurse specialist at Betsy Cadwallader University Health Board, North Wales, and she's worked in this field for the last 4 years. As part of her role, she's involved with the identification and carrying out of root cause analysis on all cases of hospital-acquired thrombosis, education, audits, organising and presenting at symposiums and presenting at thrombosis events. From presenting local data, case studies and giving real-time feedback to clinicians on her thromboprophylaxis walkaround and clinical governance meetings, she has increased compliance in thromboprophylaxis and decreased the number of potential preventable HATs across the trust and the health board. Her work has been nationally recognised, receiving multiple awards and gaining national exemplar site status for her health board. So a huge achievement, an absolute pleasure and honour to introduce Christine. Over to you.
Thanks, Stu. So my name's Christine. I'm the thromboprophylaxis specialist nurse here in Glenclwyd in North Wales. I'm going to give you a very brief outline on achieving VTE exemplar status and a bit of background on how our health board achieved it as well. So the history of VTE prevention really came to the forefront back in 2005 from the House of Commons Select Committee report. In 2007, we had the first NICE guidelines on thromboprophylaxis that was published, as well as the VTE Exemplar Network was established back in 2007. 2010, we had the National VTE Risk Assessment Tool published, and recently in 2018, we had the revision and update of the new NICE guidelines on VTE prevention, guidance and hospitalisation. So exemplar centres include both public and private sector organisations, specialist centres and DGHs throughout England and Wales. The network's led by Professor Arya, who's the director of King's Thrombosis Centre, with the aim of reducing avoidable death, disability, mobility and from hospital-associated VTE. So these are our VTE exemplar leads. We've got Professor Arya, who is the director of King's Thrombosis Centre, and also Emma G, who's the specialist nurse in VTE at King's as well. And they say that a VTE exemplar centres form a diverse and enlightened network of hospitals that have an existing track record of excellent VTE prevention and care, offer practical support and advice to other centres by sharing their resources and collaborate on clinical research into VTE prevention. So by becoming a VTE exemplar centre, it acts as a kite mark for VTE prevention care, and it confers quality to both your patients and commissioners. It enables you to give access to a community of healthcare professionals who are interested in quality and innovation in VTE. And it also allows networking and sharing of resources and ideas, as well as being there to recognise the excellence in VTE prevention. So any healthcare organisation in England and Wales can apply to be a VTE exemplar centre, providing they can give evidence that they match the criteria for it. So if you wish to apply for exemplar status, you can go on VTE England's website, and there's also a link on Thrombosis UK's website to this page as well. And on the right hand side, you will see this form, which you add your details into it, consent and submit it. After you submit your details on this form, you will get an email from the VTE leads asking you to submit your evidence for the criteria. When I submitted my evidence, I did it per section. The criteria can be divided into 6 sections. So you send your evidence for each section then. Once the VTE leads have reviewed all your evidence that you've sent, they will then be in contact with you to arrange an interview. So this will either be a face-to-face on your workplace or by video call. Through the interview, they will question and ask you things on your evidence you've submitted, what your practice was before and how you've developed that practice, and your results, and how you work with your clinicians to achieve best practice. And then once you've had your interview, the VTE leads will let you know whether you've got exemplar site status or not. So the criteria, like I said, is up to 6 sections. So the first section of the criteria is about your VTE strategy. So the first thing that you need to do before you apply is to get your chief executive endorsement, get a letter from your chief exec saying that it's happy for you to apply for exemplar status and will support it. Then you have to give evidence of your thrombosis committee groups and also evidence of what VTE guidance you've put in place. This is for your clinicians in maternity units and also your extended prophylaxis. The section 2, which is the biggest section and the most data heavy section, is about your compliance and process. Now this is quite data heavy because it asks for a lot of audit data to back up your claims that you're hitting your targets. So it focuses on your risk assessments, what risk assessments that you use, and your data showing that you are achieving the 95% compliance rate. It also asks you about your processes on your root cause analysis and how this is undertaken. So, we can send a flow chart of how you do it, and also how you do your lessons learned and implement the lessons learned in practice. It also asks you for a lot of audit results, including your results showing how much percentage of your patients are receiving the appropriate thromboprophylaxis, and also about the information given to patients on admission and discharge. It also covers the reporting and the governance of your data and how you share these tables of the data of number of hats and the learning and how you've improved. And also about the commissioning on where you submit your RCA reports to and what comes out of that and how do you advance from it. So it is quite data heavy, this section. Section 3 is about your training and education. So this is showing them evidence that you do have appropriate thromboprophylaxis training being given to your staff members. So it's to cover VTE plus the thromboprophylaxis side of it as well. And also evidence that you give a VTE education during the hospital's induction. This will be to the new staff, junior doctors and nurses, midwives. I also include pharmacists in ours as well. And also it's about your own learning as specialist in the area, that you do attend national conferences such as Thrombosis UK conferences in order to enhance your own learning to then pass it on to your fellow clinicians. So section 4 is about your communications, and this is your communications to your staff, your patients and your hospital patients. Now, the main thing is this is your VTE communication strategy that you've got in place, and the communication can be in any form, such as internal, what emails and alerts you send out to your staff. It can be about campaigns, it can be things you do to raise awareness for National Thrombosis Week, it can be the use of social media. If you've written any blogs or papers, you can submit it all under this section as well. And also, what evidence and information do you give to your patients to raise the awareness of VTE as well. So section 5 is about your implementation. This is really about establishing good clinical leads in your trust, getting VTE champions and link nurses to help drive thromboprophylaxis and VTE. And it's about the roles and responsibilities of these champions and link nurses and how you roll it out and how it helps to develop the hospital as a whole. And so section 6 is about patient and community. So this really focuses on the patient care plans you've got in place. What education would you give patients if they need to self-inject, if they go home with extended thromboprophylaxis, for example, and also about the transition into community, because we have quite a lot, especially in North Wales, that go into our community hospitals or get discharged home into primary care with extended thromboprophylaxis or ongoing management of VTEs. And it's how do you link with these community sites and primary care to ensure the safety of the continuing thromboprophylaxis management. So that's the evidence that you've given for that, but you'll be judged on for your assessment. And so I thought I'd just give you a very quick outline on how we found the process of changing our practice and applying for Exemplar Site. So this is Glenclwyd Hospital in North Wales. This is where I work, and this is how we became our Exemplar Site status. So in Glenclwyd, we made several quality improvements, which then enhanced our practice and improved patient safety. This led to us and one of our sister sites, Wrexham Marlow Hospital, also in North Wales, to become the Exemplar Site status, became the 33rd Exemplar Site. So I just wanted to briefly touch on the difference between the compliance in England and Wales and how it's driven. So in England, the compliance is a nationally mandated quality requirement. It's previously been a national secret indicator. You've got associated financial consequences. You've got one national risk assessment tool, which is the Department of Health tool on screen, and your compliance must be over 95%. So the majority of hospitals in England have electronic records and risk assessments, part of your clerking process. So it makes it compulsory to complete a risk assessment in order to proceed with your clerking. And a lot of hospitals in England either have the risk assessment printed on a drug card or in with the electronic drug card. So it does get reviewed regularly once the drug card's getting written. And it's also driven by financial consequences. However, in Wales, the Chief Medical Officer will just recommend that all adult patients undergo a VTE risk assessment. However, currently in Glenclwyd, we use about 10 different risk assessment tools. We are in the process of swooping over to the Department of Health tool, which will decrease our number of risk assessment tools we're using. We currently have no mandatory compliance target to reach, and we have no financial consequences for not reaching any targets. Currently in North Wales, we have no electronic records or risk assessment for the clerking, so it's all done on paper. So historically, the clinicians, if they didn't want to do the risk assessment, they would just turn the page and that would be it. There'd be no enforcement of that. The risk assessments aren't printed on our drug cards, so they don't get regularly reviewed when the drug card gets rewritten. And we have no financial consequences for not doing it, so it's not driven that way. So because of this and the difference in the compliance being driven in Wales, historically our hospital has struggled with poor compliance in completing the VTE risk assessment. We've had several incidents of incorrect thromboprophylaxis prescriptions which have led to patient harm, and we had a high rate of potentially preventable hospital-acquired thrombosis, the HATs. So when I started my job back in August 2017, I was speaking to my clinical lead and he said, "Kristen, the first thing we need to do is sort out the risk assessments." I said, "Why? What's wrong with them?" He said, "Oh, nobody's completing the risk assessment." Now, I just come from working from a busy acute teaching hospital from England. And so I thought, well, it can't be that bad. So when I started my job, I said, let me audit. So I audited 5 random case notes on every adult admission ward in Glenclwyd. That was back in September 2017. And the results of our audit showed that was only 34% compliance in actually completing the risk assessment tool, and was only actually completing the drug card and prescribing thromboprophylaxis 77% of the time as well. So because of this, I set a goal to increase compliance in completing VTE risk assessment tool on admission by 30% by August 2018. Now, because I was new and enthusiastic in my role, I also did a stretch goal to reduce Glenclwyd's potential preventable HAT rate by 50% by August 2018. So because of the results, we decided that a new approach was needed. Obviously, the process they had before wasn't working. So we decided on the intervention of starting a thromboprophylaxis walkaround in order to assess the compliance. Now, by doing the walkaround, this enabled us to give real-time feedback and education to all the staff and patients that we saw. And we commenced this in September of 2017. So every week, we audited 5 random case notes on all the acute admission wards included. So, like every quality improvement project, the messengers are really important. And I think this is what the key to our process was our team. So in Wrexham, we've got Lisa, who's the thromboprophylaxis nurse, and her clinical lead, who's Dr. Watson, who's a consultant haematologist. We've also got a camera shy pharmacist that's not in the picture. And then in Glenclwyd, we've got my clinical lead for thromboprophylaxis, who's Mr. Hannah, who's a consultant orthopaedic surgeon. We've got myself representing the nursing side, and also we have Heyman, who is our lead pharmacist surgery in Glenclwyd. And so I think the strength of our team is by having a lead in each of the disciplines that we was asking to change the practice and change the way of working. So because we had a lead for medicine and for nursing and for pharmacy, it really helped to get all the clinicians on board and to buy into the project and accept the messages and education we was given, which helped increase the compliance and drive the project forward. So this was our original result. So originally, September 17, with only 34% compliance in completing the risk assessment. We did it for 9 months walk around, and it showed we'd increase our compliance up to 84%. Now, originally it was only completing the drug had 77% at the time, and by 9 months it went up to 95%. So this is our monthly result of our walk around result. And so all these data went into our section 2 when we sent it away for our evidence that we meet the criteria. So it's September 2017, where the yellow circles are, is where we commenced our walk around. Now, what we originally did was we set our initial targets on the junior doctors, because they was the ones mainly doing the clerking and missing the risk assessments. Now, what we learned is that every couple of months, the junior doctors rotate to a new area, and then our compliance would go back down, and we'd start the process again and go back up. So we changed tactics and actually got the consultants to be on board driving it alongside with us, which helped us maintain it. So what happened is, as you can see, the orange line is surgery results, the blue line is medicine results. And as more and more consultants got on board and tried to drive it with us, not only was we improving our compliance, but we was actually sustaining it. And so it didn't matter when the junior doctors rotated, the compliance would still be there because it was being driven by the nurses and consultants as well. So the green circles shows the point where the majority of consultants bought into our project and helped to drive it. And that showed that we started sustaining our results above the 95% England target. This was really important for us because currently we don't have targets to achieve, but for us to be able to achieve our results against English targets was really important, showing that we can be just as good as English trust as well. So when Lisa came into post in 2018, she took the final form of our walk around and implemented it with their clinical lead into Exemplar Hospital. Now, what they found is by taking our approach, our finalised polished approach, is that they got exact same results in both medicine and surgery, but only faster. They've achieved English targets within about 6 months. And this is just some interesting data that came out of our walk around. So from the first 3,000 patients that we audited, we found that if the risk assessment was completed, the prescription was correct 97% of the time. As where the risk assessment was not completed, the prescription was only correct 65% of the time. So this was really important for us to show to our clinicians that if you complete the risk assessment as a tool as it's intended, then you will have a good result, as in making the correct prescription for thromboprophylaxis. But if you use it as a tick box exercise, you're not going to get, appropriate prescriptions as often. So this had a massive impact on our potential preventable hats in Glenclwyd. So 2017, we had 22 preventable hats, which 9 was reportable to Welsh Government because the admission was over 24 hours. So we commenced our walk around in September, and we didn't have any for the rest of the year. Then 2018, we had 4 potentially preventable hats, of which 1 was reportable to Welsh Government because the admission was over 24 hours. And the last one being in June 2018. So then we had no preventable hats for the rest of the year. And in 2019, we had no preventable hats at all. So we became the first hospital in Wales to actually achieve a year free of potentially preventable hat, which was a massive achievement and showed the great hard work from our clinicians really that attained this. So this had a massive impact on our health board. So when the Welsh Government produced the All Wales Hat Report back in August 2019, it showed that our health board, BCU, had the lowest percentage only 2.1% of potentially preventable hats in our Wales. Now, this was a massive achievement for us because back in 2017, we had one of the highest percentage of preventable hats. So, you know, this was a real attitude to how our clinicians work together to improve our practice, which resulted in an increase in patient safety. So then along came 2020. So back in 2020, early March, our hat service was suspended due to the COVID-19 pandemic. So it's been suspended just over a year now. I've just recently come back into my role. So the data collection for our RCAs for 2020 isn't quite complete yet. But however, we've already found several potential preventable hats from the year that our service has been closed. So it did make me feel like crying, to be honest. But as Batman says, we fall so that we can learn to pick ourselves up again. And I think this really is an important lesson to learn and remember, the fact that if you are granted Exemplar Site status, it doesn't mean to say that you have to be the best and all the time. It means that you have to stay passionate and enthusiastic and driven to always drive to get the best standards of practice, and also to be able to learn from what goes wrong and, you know, give that learning out to all the clinicians and other hospitals in order to advance on that and to get back. So the whole point I want to make is that once you become Exemplar Centre, to maintain your Exemplar Site status, it involves staying committed in improving practice to prevent VTE and not get dismayed if something knocks you back. You need to still strive, learn your lessons, put it into practice and still strive forward. So because of this, we're now developing some new improvement projects in order to maintain our compliance back up to over 95% and also to return to our zero potential preventable hat rate as well. This picture is just one of our improvement projects we did prior to COVID shutting us down, which we included thromboprophylaxis on every section of our theatre surgery checklist form, which really helped to reduce the number of our preventable hats from surgery. And so one thing to take away from what we've done in Glenclwyd really is that it's beneficial to have a thromboprophylaxis nurse in post, because by having a full-time nurse, you get the compliance to NICE guidelines and policies, you get delivery of education, both staff and patients, it enables you to perform and sustain at your target levels, and it also helps to be compliant in completing your RCA data as well, because in Wales we have a fixed time period where you have to submit all the data for that time period to the Welsh Government. And it's also there to support the clinical leads, support all the staff, support the hospital management team and the patients. And importantly, especially for our workplace, is that it enabled change in the workplace culture, which was essential to get people on board and talking about VTE risk and thromboprophylaxis like it wasn't done before. And this is what helped drive our processes and engagement in order to get our results. So really my take-home message, if you can learn anything from our improvement work done in BCU, is that you really got to see the benefits of having a dedicated thromboprophylaxis team, a nurse, a clinical lead and a pharmacist really work well to drive the education and support for the staff. By driving compliance through education rather than just financial penalties, you can achieve target levels. As we've demonstrated in Wales, it is delivered quite differently from England. We don't have the pressures of meeting targets or having financial penalties, but through the education we've managed to achieve and be on the same part of England. And it is possible to have zero potentially preventable hats in a year. And the most important thing is that you can protect your patients from harm and you can achieve Exemplar Site status, because back in 2017, we didn't think we'd be able to achieve it, but through the hard work working with the clinicians, we did achieve it. And I think if you can see that we've managed to achieve it, then I think, you know, everybody can achieve it, and it's something that, you know, you can strive to go for and achieve. So that's my take-home message really. So thank you so much for listening to me. So my name's Christine, that's my email if you want to contact me. If you want to contact the VTE leads, if you've got questions about applying for Exemplar Site status, they've got an email, info@vteengland.org.uk.
Thank you, Christine. That was superb and quite inspirational as well, because you very honestly said, you know, that the challenges you moved into in the hospital or the health board had faced, and you didn't hide those, but the hard work and training that came through to bring you to this exemplar status. But as important, more important, you brought on a multidisciplinary team, and as a result, certainly in 2019, had no HAP cases, which was incredible.
Yeah,
I can see messages coming in already.
Yeah.
Somebody, Mario, saying, thank you very much, Christine, for your fantastic talk, and I totally agree. Just two questions. So firstly, in regard to the Exemplar Site status, once you achieve it, do you have to apply every year to maintain it?
It's every 3 years. So you will get your Exemplar Site status, and then in 3 years' time, they will contact you, and then basically you will have an interview with them and give them evidence like, this, since we got our Exemplar Site, this is what we've done to maintain it. So for me, when it comes to my time, I will give them all my results saying we was doing really, really well. 2020 came, knocked us back. But as a result, this is the extra improvements that we've made. This is the extra, whatever projects we decide to put into place. We're changing our, you know, the way we're doing risk assessments. We're got new policy, we've got new SOPs coming out. So we plan to put the gardens in place, as well as restarting our walk around, as well as restarting the education, doing our VT conferences that we do for the health board every year. So it's about restarting the services, because everybody's been through a bad year with the pandemic, and it's about, yes, we have gone backwards, but we are still going forward as well, and this is what we've done. And hopefully when it comes to our review, we can say, actually, look, our results are improved and we're back where we was. And so, you know, we feel like we deserve it, because the clinicians have worked really hard. I think it is important when you start off in this journey is that you do get a lot of resistance. I got terrible resistance when I first started this, because especially in Wales, it's not driven in England, and even when it's driven in England, it's focusing on completing risk assessment, not actually the appropriateness. And I think the whole point of this project and the Exemplar Site is focusing on the appropriateness of the prescriptions, not just, yes, we've done it, we've ticked the box. It's we've done it for the best of that patient, for that individual patient and that individual condition.
I think you're right. Recently, obviously, locally people had reported the NHS girthed VT survey, the national report's coming out later this year. And there it still showed that even in England, where it is mandated, it is more about, it's more than ticking the box. It's about making sure that there is the right medication, the thromboprophylaxis, etc., is given at the right time, the right dose. It's checking all those things. And importantly, the patient information, which has been, I know, highlighted.
And I think that is a good point to raise, because we've struggled with we've provided all the information. This is a booklet you give out to patients, but because, you know, the amount of paperwork they have on the wards and the stress in the wards, and it is very easily to be, you know, I think clots in general and VTE prevention is not such a high agenda compared to sort of sepsis and cancer and those type of things, that it does drop down in people's priority until they realise actually the preventable deaths that come from VTE is, you know, a huge amount more than breast cancer and RTAs and sepsis, and I think it really needs to be driven nationally by all teams that this is an important subject and it is potentially preventable in a lot of cases, and you know, we need to be there for our patients and make sure they understand that as well.
Yeah, definitely. And I know you use some of the Thrombosis UK booklets, and there are many good resources out there, but alongside those, there has to be the discussion, doesn't there, with the patient, so that they understand and they can ask questions and ensure that they see where it's starting and the long-term ongoing effect and why it's so important in order for them to be part of this process as well.
Yeah, and I think that is important, the patient standing part, because the thromboprophylaxis, 90% is an injection. Patients don't want injection. for no reason in their minds. And it's to make the patient understand that actually, yeah, I know injections aren't very nice, but this is to prevent a blood clot that can be fatal, and these are the complications of having a blood clot. And I think once patients understand that, they're more than happy then to receive the thromboprophylaxis. But it is a bit of a barrier as well, just having the chemical thromboprophylaxis as more of an injection. So
yeah, and as you say, having that time and making that time. A question also that came from Mario was about, and is there any online list of those places that have achieved this award?
There is. BT England website has got a map on it. Currently, we're still not on the map, but I think it needs updating. But there is a map, and you will find a hospital somewhere around your area, because there's a fair few exemplar sites. There's 2 in Wales, 1 in South Wales, and obviously as in North Wales. The majority of them are around England. But there is a map on VT website you can go on. I
think just a few weeks ago, they went up to 36 VT exemplar sites.
Oh, perfect. Yeah.
Excellent. Another question, and again, you raised, I'm sure this is true for many people, the initial challenges of getting the right collaborators on board. How did you go about overcoming that? Because everybody's busy.
Yeah. I mean, I think to me, I'm very lucky because when I started this job, it was my first job in this hospital. I didn't know anybody. So that was a challenge in itself. But my clinical lead is very enthusiastic. He's very for VT prevention. He's been driving it himself without no nurse for a long time. So he was so grateful for the help of a nurse that he was like, let's drive it. So when I said to him, let's do this walk around, he was like, okay, well, let's just try it then. And then what happened is on our first walk around, we was in the surgical assessment unit, and we bumped into Heyman, the pharmacist. Now, Heyman is great. He's got a real interest in VT prevention, thromboprophylaxis and VT management. And he was curious, like, what are you doing? So we was explaining what we was doing and what our aim was. And he was like, oh, that's really good. Can I join? We was like, yes, because we want a pharmacist to be with us. We just didn't know who to approach. So luckily, we got Heyman on board straight away, and he helped get the rest of the pharmacy team on board. And then what had happened is, because of the real-time feedback, it helped the clinicians to decide, oh, when you're telling them actually 3-6 months ago, this patient didn't have thromboprophylaxis, now it's they're like, oh yeah, okay, whatever. But when it's like this patient here, instead what you've just seen actually hasn't had the risk assessment done, they take it on board and they learn. And even when there was against doing more paperwork for the risk assessment, they then started to see the benefit of it. And then we got the consultants on board, and we got the clinical directors on board. So now the clinical directors of medicine comes on our walk around as well. And by having the consultants and clinical directors stay into the junior staff, no, this is really important, you need to do this, and we are going to be assessing you this for your reviews and your PDRs and progressing in your medical career. It really helps to get them on board. Initially, even it's just to take notes, but once they get to know why we're doing it, which the education plays a big part, they come on willingly and voluntarily then. And I get a lot of doctors come in saying, can we do audits? Can we audit this? And how the theatre checklist came about, because I was like, I don't think it's very good in theatre. Can we do something about it? So it actually just snowballs. So you have a period of hard graft of having thick skin because people are against it, to when they realise, when you present your own results, this isn't national results, this is the results from our hospital, this is what we're not doing, or this is what we can improve on, they then take it on board. And then once they're on board, it's a positive snowball effect after that.
Thank you. And have you found across North Wales, especially perhaps with the junior doctors going out then to other hospitals, at least awareness and some of the principles that you've implemented locally are also being spread, or people are contacting you? Yeah,
I mean, we've done really well, as in we have 3 big hospitals. We cover the whole of North Wales, so it's a massive area, and we have rural areas and urban areas, so it's quite tricky in that respect, but they do rotate round. So now we have thromboprophylaxis nurse in each of the 3 main hospital sites, and we cover community as well. We work together as a team, and really by doing it as a whole VCU approach is making it better for the patients, easier for clinicians, because we're all doing the same risk assessments, we're doing the same policy, everything is the exact same, so it doesn't matter where they go, they will learn that. And if they go down to South Wales, they can take the learning with them, and if they come from South Wales, they can bring learning from them. We've had some people coming from England, which bring the learning. And I think when they come from England, they see the difference in the way it's applied as well, which is good for them to see. So I think it needs to be a national approach, but I think any learning from any site is better than nothing. So yeah.
Well, thank you, Christine. That's a
You're
fantastic
welcome.
learning experience for this afternoon. And I hope it's helped a lot of people watching. And as I've said before, this is recorded, so it will go up online. And we hope it will inspire and also support many others taking forward their centres to the VT Exemplar status. So thank you so much for your time.